Good morning. Welcome to Nor-Cal EMS Ebola Virus Disease Update. I'm Dr. Eric Rudnick, Medical Director for Nor-Cal EMS. We will be updating our regional policy and give you a greater overview of the Ebola virus disease. This regional policy will discuss how I feel and many other people in EMS region feel that it's probably not safe for local small EMS agencies to transport potentially dangerous patients who have a highly infectious disease. To this end, I've worked with SSV, and we've adopted a regional approach to transporting these patients to regional healthcare facilities, and we'll explain in greater detail that there are two EMS transport agencies that have stepped up to the plate and are well trained and have ambulances already outfitted to handle potentially infectious disease patients. A big thank you goes to John Poland of SSV EMS Agency and Kevin Perry, Regional Disaster Medical Health Specialist for Region 3, who is located also in the SSV EMS Agency. Again, thank you to those two individuals. So, Nor-Cal EMS and SSV have been working in collaboration. There are two transport agencies that have stepped up to the plate using extra funding from the California Department of Public Health, who have the required training, equipment, and vehicles to safely transport Ebola persons under investigation. These are patients who have gone to regions where there has been an Ebola outbreak, come back to the United States. These individuals were known and are known as monitored travelers. And once they start developing a fever, then they become persons under investigation. They're at high risk for Ebola virus disease, and these people will need to go to regional facilities. I feel, as well as SSV, that it's not in the best interest from a public health standpoint that these patients are transported by small rural EMS agencies. For example, if your county only has 2 ambulances and one of them is taken out of service, then you will have a very hard time responding to 911. In addition, using Ebola as the quote poster child for highly contagious diseases, then your ambulance is taken out of action, and it will be very hard to appropriately decontaminate and disinfect it. These two agencies in Region 3 are Mercy Medical Center Reading, their EMS vehicles, and Butte County EMS. Both have graciously stepped up to the plate. If it does become necessary, again, to transport a high-risk patient, then you need to notify the following agencies and/or persons to arrange for transport. You need to follow the Incident Command System. You should reach out first to the Medical Health Operational Area Coordinator, or MOHAWK, in your county. They are located usually in the County Public Health Department. It's either a preparedness person or the health officer. Then you should reach out to the Regional Disaster Medical Health Specialist, the RDMHS for OES Region 3, and myself, the Nor-Cal EMS Medical Director. We will help coordinate care. Again, you need to follow ICS so there's not duplicate ordering and there won't be confusion. Once these agencies are notified, either Mercy or Butte, it will take at least an hour for their providers to be called in, get their transport vehicles adequately prepared. Then there will be the required transit time to reach your area. We should be aware of these monitored travelers who then become a person of interest under investigation. From a public health standpoint and a community standpoint, most of these patients can wait safely in their home And unless there is some other extenuating circumstances, it is probably in your best interest as the provider not to expose yourself to these patients. If you do have to do it, then follow the training that you have been given. Again, if these agencies are not available, these local regional agencies, please go through the Mohawk, RDMHS, and myself. There are other agencies that may take a little longer to get there. So, Ebola virus. Filoviridae. The genus is Ebola virus. Previously known as Ebola hemorrhagic fever. Even though in 2014 there was a great deal of concern because of its highly infectious nature, it still is considered a relatively rare disease. However, it is very deadly. The case fatality rate is somewhere between 50 and 70%. This can cause disease in humans and in primates, such as monkeys, gorillas, chimpanzees. Ebola is a relatively, quote, new virus, only having been discovered in 1976 near the Ebola River, where it got its name, which is now located in the Democratic Republic of the Congo. They think that this is an animal-borne virus and that bats are the most likely reservoir. Some of the outbreaks are thought to have occurred because of people eating, quote, bushmeat, unquote, from animals that may have been infected with Ebola, and it crossed species that way. Again, it's considered a delicacy to eat the bushmeat. However, it is still a dangerous practice. If you are going to handle these animals, you need gloves and appropriate protective clothing. And again, these animal products, both the blood and meat, should be thoroughly cooked before consumption. Again, Ebola is a virus. There are known cures or treatments right now other than supportive therapy. There's no vaccine to date that has been effective against Ebola 100%, although people are working very hard to do that. Most of the outbreaks have occurred in Africa, and the mortality rate in the United States is expected to be lower with earlier identification, greater medical resources. So again, I hate to beat this into the ground, but Ebola causes severe illness. You need to really extra care when coming to direct contact with a traveler who has had potential exposure to Ebola and that they're showing signs and symptoms. Anything that may trigger your response, such as fever, nausea, vomiting, with a travel history, you really need to let the public health officials know. Of note is many times people who have gone to Western Africa may have such diseases as malaria or typhoid because in the early stages the symptomatology, the signs and symptoms are very similar. The potential risk for first responders in the U.S. EMS is probably lower because we're not getting patients later in the disease, that they're being diagnosed earlier, and that when you come back from an endemic area, you're considered a monitored traveler. And so CDC has actually limited the number of ports of entry into the United States. There are 5 airports that you can enter if you've been in a high-risk area. And again, this is just one of the many emerging viral diseases. Currently we're dealing with Zika. Although not as deadly, it still has great consequences, particularly for pregnant women. I've worked with some public health officials, particularly in Santa Clara County, and I think some of the media reports felt that Ebola began like a flu-like illness. Well, it really doesn't. If you're having cough, sneezing, nasal congestion, runny nose, this isn't Ebola. There are other infectious diseases that may present as flu-like symptoms: fever, malaise, aches. One of the good things about Ebola, if there is such a thing, is that patients are not considered contagious until their symptoms are present. So if you came in contact with a patient and they were just concerned and they had gone to an endemic area and that they were at risk, if they weren't having fever, nausea, aches, they are not contagious. Of note, though, is the Ebola virus disease has a 2 to 21 day incubation period. So this is really from the interval when they get exposed and infected with the virus to the onset of symptoms. So when they're talking about life cycles, particularly in Western Africa, they were talking about 21 days after the last known case presented itself, and usually they wait 2 before they declare that area, quote, free of new infection. So again, it comes and you need direct contact through broken skin. Many of us have, abrasions or cuts that we're not even aware of, so these are entry into our system, or through the mucous membrane, such as your nasal passages, your oral cavity, your eyes, and it's with blood or any bodily fluids. Now, this is different than a lot of other diseases in the fact that it's felt that sweat, for example, can carry infectious particles, Ebola virus. So urine, saliva, sweat, feces, vomit, breast milk, and semen of a person who is sick or has died from Ebola, if you come in contact, you can contract the disease. Obviously, if you get exposed to syringes or needles and get a puncture wound, you can get the disease. Something called fomites, or if there's bodily fluid on a table and it's still moist, you can contract it from that. So this is good public health safety anyway. I've seen lots of EMS providers who take care of an infectious patient, whether it's Ebola or whatever other disease, have gloves on and don't change their gloves, get into the cab of the ambulance and then touch the steering wheel. All you've succeeded in doing at that point is contaminating your steering wheel, because when you go into the healthcare facility and you change gloves and you come back out, you're not thinking that you've contaminated your steering wheel. So you grab the steering wheel, if there's fluid, moisture from that patient, and then you say, have your morning bagel, you potentially have contaminated and infected yourself. So really watch good hygiene, changing gloves frequently. Again, infected fruit bats or primates can expose humans to the EVD, and it has been sexually transmitted, that people who have actually recovered from the Ebola virus, semen from them still carry the virus and shed the virus for prolonged periods of time. So any sort of oral, vaginal, anal sex can infect people. So signs and symptoms of Ebola include fever. When I'm talking about fever, anything over 100.4 degrees Fahrenheit. When this outbreak first started, they thought it was much higher fever, 101.5, but that has actually been shown to be lower at 100.4. Body aches, headache, nausea. Again, this is very difficult in the very early stages to differentiate from any number of other diseases that you may have been exposed to if you're traveling overseas. Approximately 4 to 6 days afterward, you get nausea, vomiting, abdominal pain, diarrhea, and we're talking copious diarrhea, copious nausea and vomiting. Occasionally these gastrointestinal symptoms can start earlier. When they start getting sick and having multi-system organ dysfunction, they can get chest pain, shortness of breath, headache, confusion. Eventually they can get hemorrhaging, both internally and externally. Complications such as shock and, again, multi-organ system failure occur. Your kidneys shut down and it's fatal. So let's talk about whether Ebola is airborne or not. technically it is not an airborne virus, and it's not going to mutate. The issue is that fluids from an infected person can become airborne or aerosolized. So if somebody sneezes on you or coughs up blood, those bodily fluids are infectious. It doesn't enter intact skin, but you need to have microabrasions or cuts, and again, the mucous membranes. So hand washing, even though you've had gloves on, after every patient contact is the best way to prevent transmission. I would highly encourage every EMS provider to wear goggles and gloves for every patient contact, no matter what. And if they have respiratory symptoms, think about wearing a either surgical mask or N95 particle respirator for your own protection. Ebola can become aerosolized, so many times if you're giving a nebulizer treatment or you're giving a mucosal atomizer device, you can get exposed. CPAP may produce forced expulsion of infected saliva. So again, think about safety glasses, face shield, mask. We'll go on into greater detail, but for many of these patients, their mortality is so great and they're so sick that if they do go into cardiac arrest, there are some systems that are recommending that you don't do CPR. I don't think we're there here in Region 3, but you may want to make base contact to see how invasive you should be. I would prefer you use BLS procedures, so instead of intubating the patient, do BVM. And CPR in the back of a moving ambulance truly does expose you. So let's talk again about a person under investigation. It's a person with both consistent signs and symptoms of EVD, Ebola Virus Disease, and risk factors. So have they been to an endemic area? Do they have an elevated body temperature or subjective fever? Headache, fatigue, muscle pain. Again, vomiting and diarrhea follow a little later. Abdominal pain. You may think that they presented with nausea, vomiting, and diarrhea immediately. They may have been running a low-grade fever and not been aware of it. And again, if you have an epidemiologic risk factor and you're still in that incubation period, you are at risk. So let's do a few definitions. An Ebola risk patient. A patient who has Ebola risk factors but is not exhibiting any signs and symptoms of Ebola. EMS screen possible Ebola patient, a patient presenting with both Ebola risk factors and signs and symptoms. A confirmed Ebola patient, that's a laboratory confirmation. There are very few labs that can do that. When we get these regional healthcare facilities up and running, they'll do the preliminary screen and then they'll go to a public health lab for confirmation. Protected exposure, again, using appropriate PPE. The guidelines that came out in 2014, really, you should not have any exposed skin. So, assessment criteria and precautions. If a public safety answering point call taker advises you that the patient is suspected of having Ebola, then again, if you do need to respond, don the appropriate PPE and do that before you enter the scene. During the assessment, you may and should consider Ebola risk factors, a relevant exposure history. Again, travel, exposure to people who have been there should be taken. Residence in or travel to a country with widespread Ebola transmission or uncertain control measures within 21 days, 3 weeks of symptom onset. Again, be careful with contact with blood or any bloody bodily fluids that have from a patient who's been known to have or suspected to have Ebola. Again, there's so many other diseases. The signs and symptoms of early Ebola may be very nonspecific. And so I think this raises the point an issue that, again, you should always practice infectious control disease measures, and you can refer to the Nor-Cal EMS policy that we have developed. There will always be new and emerging infectious diseases, and we now, in 2016 had Zika virus, for example. Again, if you have a relevant exposure history, you need to elicit this. Again, fortunately for us, is patients, well, they're not patients yet, they're people volunteering to help in other parts of the world will have a contact history, and public health will be notified about these people. Again, subjective fever of 100.4 or greater. Again, headache, fatigue, weakness, muscle pain, vomiting, diarrhea. If you are going and taking care of these patients, you need to minimize the exposure. You try to have only one EMS provider approach the patient, do the initial screening from 3 feet away. This will decrease the risk from airborne and droplets. Any patient presenting with Ebola risk factors and signs and symptoms shall be considered an EMS screened possible Ebola patient. If they're positive based on the initial screening and you suspect Ebola, again, make sure that you've got the appropriate PPE donned before you come in close contact. Again, try to keep other emergency responders away, assuring that they should be able to support you with your primary assessment. And again, no one, absolutely no one should have direct contact with a patient who may have Ebola without wearing appropriate PPE. We'll go into further detail. Any confirmed or EMS screened possible Ebola patient, you just assume that they are infectious, use appropriate PPE, suits, water repellent, double glove, boots, booties, goggles, face shield, again, no exposed skin. If the patient's not exhibiting obvious bleeding or vomiting or diarrhea, and you don't think that there's a good risk, a minimum concern for bleeding or vomiting or diarrhea, then you put on an impermeable gown, face shield, and or surgical mask, and 2 pair of gloves. That's the official stance. I would go ahead and don everything. I think an ounce of prevention is worth more than a pound of cure. SSV, and we differ a little bit. If they're exhibiting obvious bleeding, vomiting, diarrhea, and there's concern, obviously, for potential exposure to blood, vomit, you need to wear the highest level protection designed to eliminate any and all skin and mucous membrane exposure. Again, no skin, mucous membrane exposure. So, level C splash protection, full body suit that includes a hood, 2 pairs of gloves, boots, boot covers, booties, hooded face shield. Again, I would recommend an N95 or possibly even in a PAPR. Again, Nor-Cal, we talk about the surgical hood if you don't have a full body suit extending down to the shoulders. You don't need that if you have coveralls or suit provides this. Again, face shield, eye protection is key. N95 mask, PPE, impermeable gown or suit. Make sure that the seals are good. If you don't have a coverall and you have an impermeable suit, you need to mix and match sometimes with the surgical hood and the gown. Again, double glove with high cuff. Again, you need to be trained how to eventually remove your gloves and the other, doffing this in a very controlled manner. This video will not demonstrate that, but there's lots at the CDC site. Leg and shoe coverings. Again, no skin shall be exposed. Again, always exercise extreme caution when approaching a suspected Ebola patient. These people are critically ill many times later in the disease. They can get infected cerebral spinal fluid and act bizarrely. They may be suffering from a meningitis. Dehydration can make you act. They may be hypoxic, so they may be flailing, staggering, and this can put you at significant greater risk. We talk about in the Ebola virus disease prevention protocol, you need a safety officer at the scene. This is a trained observer. They should be familiar with the use of high-risk PPE as we just described. They don't do any direct patient care. They simply monitor you, the donning of the PPE, ensure the safety of you, the responder, while engaging direct patient care, and monitoring the safety of when you doff this. The CDC website goes into much greater detail on how you need to dispose of this highly infectious material. The patient care leader, usually one EMS person goes in and does the primary care, and then patient care support, you support the leader when a second provider is needed. And again, this person needs full high-risk PPE. Many systems are using an ambulance operator whose sole job is to drive the ambulance to the receiving facility. Again, I don't think this should be a small facility within our regions. They're not equipped to handle such an infectious patient, that they should be going to these regional facilities. Again, this is why you need to contact the Modoc in public health, the regional disaster medical health specialist, and the Nor-Cal EMS medical director. These specially equipped ambulances have separated compartments. There's an ambulance in the Bay Area, for example, that was specifically built for infectious diseases, and the cab and the back of the ambulance have separate air systems, and they have filters, and they have UV disinfectant capability. And when you're talking about decon, I again worry about our providers exposing themselves, using the appropriate strength bleach or other disinfecting agent. And it would be better, as outlined in our protocol, just to if you have to transport for whatever reason, the regional resources are not available, that you park your ambulance, lock it, and get a professional company to decontaminate it. Again, you need to separate the cab from the patient care compartment. You put impermeable shielding between the two. This is a lot more difficult than people think. The ambulance operator at this point can be the safety officer, and once the patient is secured in the ambulance. Again, you limit the number of providers who have direct patient care. If the patient's vomiting, then you give them a large red biohazard bag to keep the emesis. Many of them will be having profuse diarrhea, so you need to consider wrapping them to try to reduce the amount of contamination to other surfaces. So let's again talk about notification of the Medical Health Operational Area Coordinator. Every county has one. You talk to them about that this patient potentially has an Ebola virus disease, that the health screening questions are positive. You should make this contact while still on the scene by phone, not the radio. This would cause widespread panic. The first arriving pre-hospital providers who have made patient contact don the appropriate PPE, high-risk PPE, shall maintain the patient care throughout the transport to minimize potential provider exposure. Again, this is in the event that the regional assets are not available. You treat the patient according to the appropriate protocol you use. When you're trying to do invasive procedures, again, I would recommend, instead of intubation, doing BVM. If you're thinking about an IV, maybe you try to give them some oral Zofran and orally rehydrate them. Because using an IV on a high-risk patient places you at significant risk. and then base hospital should be made, contact shall be made to clarify questions. I'm not saying you don't provide care to these patients. What I am saying is you need to protect yourself as a provider and protect them also. So the Nor-Cal policy goes into great detail on how you need to do this. The CDC website and documents on the Nor-Cal website also explain in great detail. You need to have trained, which most of our providers have already, but donning and doffing PPE is deceptively easy looking, and I've been at lots of exercises where people have had dye, powdered dye on them, and they've contaminated themselves without even knowing it. Again, most of these monitored patients or monitored travelers are patients who are under the supervision of public health but are not necessarily symptomatic for Ebola. So when they come back into the country through these ports, they're screened, and the local jurisdiction, the local health officer, and you think, well, that's never going to happen in Region 3 or in Nor-Cal's counties. Well, I can tell you that yes, we have had monitored travelers, and fortunately for us, we've not had a person under investigation, because volunteerism is everywhere, and we are a community in rural Northern California that band together and want to help people. We just need to take that extra precaution to protect ourselves, because if we become ill, potentially die, or are disabled, then we can't help anybody else. So the public health officer may order the transfer of this monitored patient who may now be a person under investigation to a designated hospital. Again, those are being decided upon, and they'll be going through a CDC verification. These are different than, say, UC Davis. There are going to be 2 hospitals, more than likely in Region 3. The EMS duty chief shall initiate and support the transfer process. So, these monitored patients will be transferred to designated regional Ebola hospitals, and in some circumstances these patients may be transferred again from these regional specialty centers to either referral centers like UC Davis that have the capability to take care of a positive Ebola patient. And I just worry about our small facilities taking a patient who may have signs and symptoms consistent with Ebola, which can be devastating to a small facility because of the contamination issues. Again, the pre-hospital treatment for Ebola is supportive. Again, I think the BLS procedure should be performed in the out-of-hospital setting. ALS procedures are absolutely necessary. Then you base it upon really the patient's condition. I can't state this enough. You need to protect yourself. If you have any questions, comments, or concerns, then you contact base hospital physician for consult. You try to limit the use of needles and other sharps. Going back to OSHA standards, these needles and sharps, once you're done with them, they need to be, again, put in a puncture-proof sealed containers that are specific to that patient, because there's different levels of biohazard and the way these infectious agents and refuse is handled, and there are only certain companies that can handle this level of infectious agent. So you don't put the needles in the sharps in containers that have sharps from other patients. So pre-hospital personnel must weigh the risk benefits of the specific treatment. And if this patient goes into cardiac arrest, doesn't meet the termination requirements for death, you're going to have to do resuscitation. Again, with any resuscitation, with CPR, I think that CPR is of the utmost importance, and I wouldn't focus so much on advanced airway. Again, I would do BVM, bag valve mask ventilation. I think we've talked about the invasive resuscitation procedures such as endotracheal intubation, open suctioning of airway, enough already. Again, in a less controlled environment, the risk goes up. If you have to transport to a local facility, you definitely need to give them a heads up. Again, if you're notifying regional transport agencies, then you need to let the Mohawk know, the RDMHS, and they'll let the regional facilities within Region 3 know. So, thank you very much. There's a Nor-Cal EMS infectious disease module, Protocol 102, Ebola prevention protocol. There is infectious disease control measures, SSV, EMS Ebola guidelines from 2014. There's the guidance from the California Public Health Department on their website, and then again there is the CDC website. Thank you very much for your attention.